what is recommended diet for someone with Sezary? But I think maybe if we can answer, is there a recommended diet overall?
I've been asked that multiple times. I always tell my patients a good, healthy, balanced diet is the correct diet. There's nothing that we know that definitely predisposes to Sezary or that makes it worse or better. And, you know, the treatments can cause side effects themselves. The condition is something that takes quite a bit out of the patient. So I think looking after yourself and having a balanced diet is key.
Yeah. And, you know, a lot of our patients do come in with questions about supplements during chemotherapy. And so, you know, we would review those with you, and you should review that with your treating physician if you are on active chemotherapy about supplements as well. But what I like to do is use an opportunity to talk about diet as a state of general health and to improve, you know, diet and your eating habits and you know, increasing the amount of antioxidant type foods in your diet have some benefit. And so we usually go into conversations about health, and because diet just isn't a treatment for cancers, but it can just improve overall health if you pay attention to your own diet.
Well, the doctors always tell us to eat healthy and stay active. So no matter what, that's what we should be doing. How is large cell transformation confirmed diagnosed with someone who has Sezary?
So typically with large cell transformation, the disease is sort of taking off. I say it's sort of progressing rapidly. It's not doing the usual kind of thing that we're used to. And most of the times it's with larger lesions that appear on the skin. So often there'll be thicker plaques or large tumors that appear rapidly and suddenly. And the diagnosis is made by a skin biopsy because there are certain features that the pathologist will look for under the microscope to specify whether it's large cell transformation or not.
What markers are used to determine the best course of action treatment for someone with Sezary? Context: a PET scan showed swelling in lymph nodes, so my mother was put on 6 rounds of CHOP. Is this a common and effective treatment path?
Okay. Yes. Yeah. You want to take that first, and I think both of us probably.
Yeah. I mean, I'll let you. Yeah.
Okay.
Therapy.
Yeah, no problem. Yeah, it's a chemotherapy question that is my specialty. So, I think it's if you have a new diagnosis of Sezary, there are a number of treatments that are available that don't fall into the category of traditional chemo like CHOP, and those can be considered as well. And we mentioned a few of them here on this call already. Drugs like mogamulizumab, drugs like romidepsin. These are good for helping to clear out the Sezary cells from the blood. And so while CHOP might be effective, it may not be good at maintaining the response. And so the key really is disease control after that initial response. So I would recommend, you know, asking the oncologist to consider some form of maintenance therapy to help the disease prevent it from coming back, really. And there are not very many treatments that prevent. There are not many time-limited treatments like CHOP. You get 6 cycles and then you stop. But after stopping, there's a high risk of it coming back. And I would also say that Sezary, not all Sezary needs to be treated. We have success with a blood procedure called photopheresis, which I mentioned earlier. And that alone, that procedure, it's a blood procedure where we take out blood, we treat it outside of the body with UV light and a chemical and return the blood back to the patients. And that treatment alone is not chemotherapy, and it's very effective at controlling and at treating Sezary. So that might even be a nice option if it's available in your area, to consider something called photopheresis as maintenance therapy after CHOP.
Is it important to treat LCT in Sezary with the mentioned treatment options like photopheresis in tandem with chemo being used to target swollen lymph nodes? Or should these things be treated in silo? And remember the disclaimer from the beginning that the doctors can give their opinion based on what they have seen, and please do not take these as second opinions.
Yeah, so I think we mentioned earlier, if you had joined earlier, about different treatments for large cell transformation. It is one of the areas where the disease becomes more, can be more aggressive, and so it definitely needs to be treated more aggressively at that point. And so in terms of the treatments, we mentioned different chemotherapies that can be used. Doxil chemotherapy, brentuximab vedotin. We don't usually, for large cell transformation, we don't necessarily need to pair it concurrently with photopheresis. But I think what we had mentioned earlier is that if large cell transformation were treated with, let's say, radiation, total skin electron beam radiation, or even focal radiation, sometimes maintenance treatment with photopheresis can be applied at that point. And it's also important to know if there's, I think your question is if you have Sezary cells in your blood and you also have a diagnosis of large cell transformation, that would you need photopheresis at that time? I think photopheresis is a great treatment for blood disease. It tends to be very active in patients who have active Sezary syndrome in their blood. And those are the patients that I would recommend it. But it doesn't need to be concurrent to your treatment. It can be considered afterwards, if that helps.
Have you used low-dose subcutaneous treatment with Campath for patients with Sezary? Not the traditional infusion at 30 milligrams, but rather the 10 milligram subcutaneous injected low-dose regimen, which I have read is less toxic to the immune system. It's a very well-asked question.
I can answer, and then maybe Dr. Sani can answer as well with her experience from her group. We have used it, and this data actually came out from centers in Boston, Dana-Farber, etc. Have the most experience with the Campath regimen. I have used it, but I am not as enthusiastic as some of my Boston colleagues in that it does tend to deplete the immune system, not just B cells, but not just T cells, but B cells. Even at the low doses, we do recommend patients go on multiple anti-infectives to prevent infection because of the immune suppression that does occur. I think we have a lot of other options that I would use before using Campath, but that's just my clinical experience. And but a lot of places in Boston will recommend Campath for Sezary. It's not my first choice, but it is an effective option when I feel like the other choices are not cutting it.
I actually agree with Dr. Lansigan, even though our practice is in Boston. We experience where it's not our first go-to drug. We don't love it. That doesn't mean it doesn't work. It has its place. It can work. And it's all about the risk-benefit ratio. Like you said, there are other drugs that are available that have a better safety profile, that we're more used to using and seeing good responses. So we would always go with those ones first. But Campath is known to work, definitely.
What are the mandatory tests for diagnosing and staging Sezary syndrome? Is a lymph node biopsy necessary when the PET scan shows enlarged and active lymph nodes?
So I can start with this one. So with Sezary syndrome, the most important thing is that you are evaluated by a specialist that is familiar with the diagnosis and knows how to make this diagnosis. It can be very challenging. And since Dr. Harden and I have been practicing in cutaneous lymphoma, we have encountered many patients that quite likely have had Sezary syndrome for several years prior to meeting us. And it's just been simply too difficult to establish a diagnosis when providers are less familiar with this very rare subtype of skin cancer. So the most important thing is to identify first the skin infiltration. And so the classic textbook pictures of total body erythroderma or redness of the skin, and perhaps many of you who have skin lymphoma have already looked up on the internet what that might look like. And there are a few representative pictures, but that by no means represents how all patients actually present with their skin erythroderma. Many patients with different skin tones or skin colors based on genetics and ethnicity have a different appearance to their skin. It may not be as quite classic bright red as others. So that's where it's really important to have a provider who's familiar with assessing the skin. Many patients might have simply flaking or infiltration or almost swelling of the superficial layers of the skin that we're able to identify. And it may not be as classically total body red, and may also initially not involve the whole body. We've had many patients who present first with redness or infiltration of their skin to their face or upper torso before it becomes all over their body. So the first thing is a really careful skin exam. The next thing that's very challenging is evaluating whether an individual has circulating Sezary syndrome or Sezary cells in the bloodstream. And this requires a specialized test called flow cytometry, and also a very coordinated approach with your laboratory colleagues or pathologists who work in the flow cytometry lab to provide an adequate assessment of the individual blood cells to see if they are Sezary cells or not. It's important to know that patients can have Sezary syndrome without necessarily having an absolute rise in their lymphocyte count as identified on a simple blood count in the lab. Rather, you need the flow cytometry machine or assessment to identify the clone of Sezary cells and then enumerate them to see if an individual meets the criteria for Sezary syndrome. So in summary, I would say that to evaluate or diagnose a patient with Sezary syndrome, you both need an expert skin assessment and an expert blood assessment to establish that diagnosis. I think there was a second part to the question about the use of a PET scan and the necessity for lymph node biopsy when establishing the diagnosis of Sezary syndrome. I would comment that it's frequent that patients, particularly with new undiagnosed Sezary syndrome, will have enlarged lymph nodes. And in fact, that's one of the sort of triad of an individual with Sezary syndrome has both lymph node enlargements, red skin, and clonal Sezary cells. I would say, though, that even if identified that they're slightly enlarged, it is not required for the diagnostic criteria to have a lymph node biopsy proving that someone has Sezary syndrome. You would find the same cells in the skin and the blood in the lymph node, but it's not necessary for meeting that diagnosis. So we sometimes do not pursue a biopsy. It's just another medical intervention that isn't required. And similarly, we don't necessarily need to do a bone marrow biopsy to establish the diagnosis of Sezary syndrome. So our approach is to avoid unnecessary tests and just make sure that the tests we are using are effective.
I have Sezary syndrome, and the skin on my hands is peeling off and being replaced by hard skin, which in turn starts to flake and becomes very painful and dry. I've tried cotton and latex gloves. The latter will help for a few days until my hands look they have been in water for the same amount of time. Can anyone or anything help?
This is very difficult. A lot of Sezary patients have really thick scaling both on the hands and the feet. You can get cracks and fissures, and it can be very painful and sore. You can have bleeding, and it's awful, honestly. It's difficult to treat. The gloves occlusion can be very, very helpful, but you definitely want to combine it often with a moisturizer. One of the things I like to use is just plain old Vaseline. It's not very expensive. It's kind of thick and goopy. It doesn't tend to burn on the open or raw areas. I like it better with the cotton gloves. The latex, like you described, sometimes can make your hands kind of soupy, and you can kind of have skin breakdown when your hands are soupy. So I usually recommend to my patients who are having a big problem using just plain old Vaseline at night, so they're not getting it on everything, and wearing white cotton gloves to bed. So you put the Vaseline on and you put the cotton gloves on and you go to sleep. And hopefully by the morning, your hands feel a lot better and you're not spreading Vaseline all over everything. And you can do the same with the feet too, if they're experiencing it with white cotton socks.
I remember when having dry, cracked skin as a kid, my mom would always put Vaseline on my feet, put the big tube socks on before you went to bed. It always felt so good the next morning. Yes. What are the current promising studies for Sezary? How might CAR-T treatment fit in? I know you mentioned CAR-T lightly earlier, and I just want to add that we do have a few videos that we did in our foundation YouTube library specifically about what and how CAR-T works. So if you want to go to the Foundation's YouTube channel, we do have a few videos we've done to help explain it, because sometimes new science can be a little challenging to understand. So I don't know who would want to tackle that one, or if you want to let them watch the videos.
No, so for Sezary syndrome, right now, there are certain treatments that are kind of approved at this time. Of those options, mogamulizumab and romidepsin works pretty well. When we are thinking about more intravenous therapies, of course, even prior to that, there is a role for bexarotene as well as photopheresis, which can be pretty effective, and a lot of people can get a lot of mileage out of that for a long time. Photopheresis is usually very well tolerated, so we do try to get as much out of it as possible, and it can sometimes also be used to supplement therapy. Once we go to our other IV therapies, we can still use some of these treatments as supportive to minimize side effects that comes with some of these intravenous drugs. So but in going to the future, there is a CCR4, a drug that is similar to mogamulizumab is in the pipeline, which acts on the same pathway, but it's a different, just a different drug. And there are a number of others. Like I said, we have a study with pembrolizumab, which does tend to work well for Sezary syndrome patients. So that's an immunotherapy agent. And so there are quite a few options in this day and age. And so as far as CAR T cell therapy is concerned, definitely that is more in infancy when it comes to T cell lymphomas, because we do tend to see a lot more toxicities with the kind of products that have been tested so far. And so definitely it's a work in progress, with the exception of maybe CD30 CAR T cell therapy that can be used in patients who have CD30 positive disease.